So, well, good morning, everyone, and welcome to our Monday lecture series. Today, I have the honor to present Dr. Gustavo Pradilla, who is an associate professor in the Department of Neurosurgery at Emory University and chief neurosurgery at Grady Memorial Hospital. He will be talking about the ENRICH trial, efficacy and safety results as the first successful surgical ICH randomized trial. Dr. Pradilla graduated from medical school in 2002 at Pontificia Universidad Javeriana in Bogotá, Colombia. And following this, he completed a postdoc fellow in cerebrovascular neurosurgery department at Johns Hopkins, where he also trained as a neurosurgeon and completing residency in 2012. In 2011, he did a neuro-oncology research fellow in the NCI Sydney Kimmel Comprehensive Cancer Center. And in 2013, he completed his fellowship training in vascular and skull base at the University of Miami. He was named associate professor at Emory University in 2019, where he also serves as director of both the cerebrovascular research and the microsurgical neuroanatomy and skull base labs. And since 2013, he has been the chief of neurosurgery and co-director of the skull base surgery center at Grady Memorial Hospital. As you can see here, he has been recognized with many honors and awards, such as the Galbraith Award of the AANS CNS Cerebrovascular Section and the Harvey Cushing Contrarian Research Award for the highest achievement in neurosurgery research in 2004. He also received the Order of Merit in the city of Bucaramanga, Colombia in 2009, awarded by the mayor of the city to its distinguished citizens. And in 2011, he was awarded the Walter Dandy Award for excellence in neurosurgery. In 2014, then he received the 1 in 100 Outstanding Postdoc Mentor Award by Emory University, and also the Christen's Legacy of Love Chair of Research from the Brain Aneurysm Foundation. And last but not least, in 2019, he was recognized with the Neurotrauma and Critical Care Paper of the Year, where he studied the intracerebral hemorrhage score, a self-fulfilling prophecy by the CNS. We can appreciate here his outstanding contributions to the neurosurgical field by looking at his different highly cited publications over the years. And with a H index of 33 and 40 on Scopus and Rule Scholar respectively, and over 5,900 citations. It's an honor and a pleasure for me to present Dr. Gustavo Pradilla. We made this plaque for you on behalf of the neurosurgical department. Just a way to thank you for you to be here.
Thank you so much for that introduction.
No problem.
Beautiful. Thank you, guys. Thank you.
And Gustavo, just so you know, Emiliano, why do we have Hamid also joining virtually right now, and from where?
We have over 40 virtual participants over 10 different countries, including Argentina, Colombia, Dominican Republic, Indonesia, Italy, Mexico, Panama, among others. Welcome, Dr. Pradilla.
Thank you.
Thank you, Gustavo. And did you have it in presentation mode?
Okay. There you go. Beautiful. All right, good morning, everybody. Thank you again, Alfredo, for the invitation. I have so many connections to this department, so many friends over the years. First was Alfredo. When Alfredo was interviewing for a faculty position, I met him in the hallway. He was running around with my friend and mentor, Alex Olivi. He was going to interviews, and I had the chance to meet him. I said, who is this guy? He's like, hurricane of energy and excitement, and we were so lucky to get him in the faculty. And he was looking for people to set up his lab. And I had this undergraduate student who was incredible, and I hooked him up. Gretel Zamora, she's now an anesthesia faculty at Harvard.
Yeah, más lleno.
Phenomenal person. And then he said, I need a medical student. And I had this guy, I said, I'm gonna hook you up with the best student I've ever worked with. That was Kaiser Chaichana. So Kai was his first student in the lab, and the rest was history.
But you also, Kai was thinking about going into orthopedic surgery, and you convinced him otherwise.
Showed him the light. So anyway, we have a long history of friendship and mentorship. My 5th year, I really wanted to spend some time with a master, and Alfredo called Mike Lawton, and Mike took me in for a few months, and it was a huge experience in my life as well. Thank you.
Thank you,
for
Gustavo.
everything. So what I want to share with you today is something that very exciting for all of us in neurosurgery. And it's the results of a multi-center randomized clinical trial. Mayo here was a site in our trial. Dr. Freeman and Dr. Chaichana were the co-site investigators for this. When I was thinking about doing this trial, I was actually meeting with Chris Fox and friends in Miami. Must have been 6 or 7 years ago. And I asked them, I said, it's a good idea. I said, you should do this. Okay. So here we are 7 years later after that. So here are my disclosures. The most important one is that the trial was funded by Nico Corporation, and they make 2 of the devices that were used in the procedure evaluated in the study. This is the map. One slide. This is the map of stroke deaths in the US. This is updated up to 2020, but the darker colors are the more patients. And one of the reasons why I was interested in this is because, like you are, we are part of what's called the stroke belt. And we see a huge number of these patients. And when I started my practice at Emory, one of the things that frustrated me was that our ICU was always full. I could not transfer patients in. When we looked at who were the patients that stayed the longest, ICH patients were among the highest length of stays we had. We had nothing to offer for them clinically, and they were there for a long time. So that lit a spark and I said, we have to do something for these patients. When you look at cerebrovascular disease in general, this is the pie. So we have about 750,000 strokes a year. If you take 600,000 ischemic strokes, you have 150,000 hemorrhagic strokes, 30,000 surviving hemorrhages. That's about 120,000 ICHs. So it's a substantial number of patients that we're talking about. And when we look at how those patients do, the early mortality is very high. Even with the best critical care, 30 to 50% of these patients die early. And when they survive, about 80% have significant disability. So it's a high burden of disease. We spend about $12.5 billion taking care of these patients, from their acute care to when they make it to long-term nursing, LTAC, etc. So it's an important disease. And when we look at population-based causes of disease, the causes of ICH are becoming more prevalent as people age. They have more hypertension, more amyloid angiopathy, and we have more patients on anticoagulation than ever before. So this problem is only going to get worse over time. So when we think about intervening in these patients, there are 3 key reasons why I think we should remove these clots from the brain. And I'll go through each one of these, but the first one is control of intracranial pressure. The second one is the prevention of clot expansion. And the third one is to prevent secondary inflammation. So ICP control is clear. If you have a hemorrhage that's greater than 30 cc's, that's going to generate a fair amount of intracranial pressure. And that happens from the pure mass effect side of things. But as we probably all know, there is a fair amount of perihematomal edema that forms over time, and that leads to even more intracranial pressure issues. So something that can really remove that out of the equation can make a significant difference in these patients. Now, when we look at mortality, half of these patients die from ICU-related complications. So one of the important things for us was to try to get these patients out of the ICU as soon as we could. So let's say we can't make them better neurologically, but instead of spending 12 days in the ICU, they spent 9 days in the ICU. The incidence of all of the medical complications, pulmonary embolism, pneumonia, sepsis, et cetera, will go down, and that will save a lot of lives as well. So that's the first reason. The second reason to get these patients treated is the prevention of clot expansion. So as you probably all know, there's a phenomenon called a positive spot sign. So you get the patient in the ER, you get a CT angiogram, and they have active contrast extravasation. The group of neuroradiology at Harvard, led by a Colombian friend of ours, Javier Romero, did a lot of work in understanding how these patients do, and they are among the patients that do the worst if they have a positive spot sign. And that's a picture that we commonly see, and I'm sure you see it in the emergency room. You have a patient that shows up with a scan in the left. You try to get them stable, get their blood pressure under control. You're waiting for a vet, and they call you back and say the patient is worse. Now they're intubated. The hematoma has expanded, and then at that point, there's really not much that we can do for them. So when we look at all of the patients in ICH studies, it's about a quarter of these patients will have active contrast extravasation. They're actively bleeding at the time of presentation. So that's another important thing. Can we do something about that? And then the third reason to intervene is to prevent the secondary cascade of inflammation. So when we have a patient that shows up with that scan, they may be okay. You admit them to the ICU, you start them on blood pressure control, and a couple of days later, if we don't intervene, of course, we know there's this cascade of initial events, but if we leave the clot there, there's a secondary cascade of inflammation that happens. All of these activation led by red blood cells, hemoglobin, then your endothelium and your microglia go in overdrive, and they generate this cytotoxic, pro-inflammatory, pro-oxidative state, and that causes this dark halo around the hematoma, the perihematomal. And that's when you get called 48 hours later, and the patient's ICP is out of control despite maximal measures, and now you're being called for a salvage hemicraniectomy. So that's the second reason to intervene. And we know there's a time dependency to this. The factors that are related to the timeline of inflammation are pretty clear, and we know that these patients need to be treated as soon as possible. There are many studies that have looked at what happens when you remove clots with this perihematomal edema, and if you do remove those clots, the perihematomal edema improves. And if that improves, patients do better from a neurological standpoint, and their overall outcomes improve. So if the rationale for doing surgery is clear, is biologically plausible, it makes sense, and we've probably all seen a video like this. You open that up and immediately these clots express themselves out, the brain starts to relax, and you just feel like it's the right thing to do. So why were we not doing it? So let's go into the reasons why surgery is not recommended. So this is the most recent version of the guidelines. This was revised last year, and if you look at the people in there are two well-known friends of ours, Billy Mack and Jay Moko, were part of the committee, and these are the recommendations from the guidelines. So on the medical side, there are a lot of class 1 data recommendations for doing the things that we do in the ICU. Putting patients on DVT prophylaxis, using antiepileptics, reversing anticoagulants, doing invasive intracranial pressure monitoring, etc. But when it comes to surgery, the recommendations are fairly weak. So we have class 2A recommendations that say that doing minimally invasive evacuation can be useful to reduce mortality compared to medical management alone. And I'm going to go over where that recommendation came from. And then we have class 2B recommendations that say that minimally invasive surgery may be better than conventional craniotomy to improve outcomes. But the benefit in neurological outcomes is uncertain. And they recommended that more trials be done. So that's where the guidelines left us. And this is why. So conventional craniotomy for intracerebral hemorrhage, that video that we saw, was evaluated in 2 landmark trials. And I'm going to go over those 2. Those were called the Stitch trials. They were led by a group in the UK. Dr. David Mendelin was the principal investigator. The first one of those was published in 2005 in the Lancet. It was a 1,000-patient study that was done in 27 countries. And unfortunately, the results were negative. The early surgery group had 26% favorable outcomes when compared to the medical management. And that was not statistically significant. They saw a little bit of a signal in patients that had lower hemorrhages without intraventricular hemorrhage. So they ran that second study that was called Stitch 2 to evaluate that. That was a large study with 600 patients as well. And unfortunately, the results were not conclusive. So surgical patients, 59% had an unfavorable outcome versus 62%. So a little bit of a signal, but not statistically significant. This was published in 2013, and with these 2 studies, all the subsequent guidelines that surgery does not help. And many people said it's a futile endeavor, do not do it. That's what the evidence told us.
And Gustavo, can I make a comment? Because
Yeah.
that's what I was saying. I mean, this is, and I just want all the residents and the people in the audience to realize that when Gustavo was talking to Chris and the team, because I heard about those conversations from Chris as well, you were going against what the studies were showing already. But anecdotally, a lot of us knew that this helps, and because of the pictures that you showed, because many of us have been there taking us, so you continue to pursue and persevere in your studies and diligent in creating the clinical trial that was going to show us what we're about to see.
Oh, you're absolutely right. And one of the subsequent landmark studies that we had is a study that was called the MISTY study. The MISTY collaboration had a lot of investigators, and it was led by 2 neurosurgeons, Mario Zuccarello at the University of Cincinnati and Isama Wadi versus Chicago, and 1 neurointensivist, Dan Hanley at Johns Hopkins. And the premise of this was that you put a catheter under stereotactic guidance, and then you aspirate gently with a syringe, you get what you can, and then you start an infusion of TPA, and then you wait. And after about 5 days on average, you get a good hematoma clearance. So they evaluated that, made it to a phase 3 trial, which was this MISTY study that was published in the Lancet in 2003. So they were treating patients within 72 hours with suprachoroidal hemorrhages greater than 30 cc's, and they were looking at outcomes in a year. And this is the mortality. So in terms of mortality, there was a benefit to the intervention. But their primary outcome measure, what you're seeing there is modified Rankin scores. And if you're familiar with the modified Rankin scores, 0 is an intact patient and a 6 is a mortality. So the more to the left that you see on those, the better. And there was a signal, a slight improvement, but it did not reach statistical significance. So this was very sad, very disappointing, because this was a major effort. It was a very large trial. It was partially funded by NIH and industry. And it was very disappointing. We thought this was going to help a lot of people, and it just didn't reach the mark. But we did learn a lot of important lessons there. The first one was that we had a volume goal. So they analyzed how patients did by how much residual hematoma was left. And they found out that if you leave less than 15 cc's of blood, patients have a greater likelihood of reaching an MRS of 0 to 3, of doing well. So for the first time, they gave us a goal. This is the surgical goal, less than 15 cc's. Unfortunately for them, they only got there in 59% of the patients. So we thought, this is great, but is there something that can get us past the goal? How can we get to over 59%? And will that make it a significant effort or not?
And Gustavo, one parallel right here is the study that I published a number of years ago with work that he did also review, and the residual for brain cancer for the first time, showing that it was about 13 to 15 cc's of brain cancer was negatively affecting. So, basically bringing us back to the fact that what we leave behind is as important as what we take out. This is an interesting parallel. I wasn't aware of this data for you.
Putting data validated metrics for surgical success is hard. But now that we have so much volumetric data available, those are becoming more important. So we looked at all of these data and then we said, if we have unlimited resources, unlimited opportunities, what is the best we can come up with? So we said this would be an ideal surgical procedure for ICH. It should immediately relieve the mass effect. It should maximize clot removal, minimize the injury as you're doing the procedure. You should be able to see to get hemostasis. It needs to decrease the length of stay, and it should decrease the overall costs. This is the most you could hope for. And then we said, based on that, let's design a procedure that could potentially deliver on those things. And that's what we came up with. So this is a cartoon that symbolizes the approach. So the approach is based on using image analysis first. So understanding that not every clot is the same, not every location is the same. The lobar hemorrhage is different from a basal ganglia hemorrhage that involves the caudate and the putamenal region. And that's different from a thalamic hemorrhage that dissects into the midbrain. So let's understand where these are, then let's design a trajectory to get to them that is less disruptive. So let's not go for an anterior temporal lobectomy to get to a deep clot. Let's try to find a trajectory that is less morbid and see if that will get us there. So that included using this minimal access ports, and what we used was the brain path port. It's stereotactically guided when it goes in. It takes into consideration the white matter tracks that are on the way, and we're trying to pick not the shortest distance to the hematoma, but the most white matter sparing trajectory to the hematoma. And then once we're there, it had to be something that would give us maximal classic microsurgical technique. I need to be able to use suction, a bipolar, and microdissecting instruments, and do conventional high-level microsurgery to avoid injuring the patient even more. So that was the approach. This is an example of that. This is patient coming in with a basal ganglia hemorrhage, and that's the trajectory that we think we want to get. I don't know how to get rid of this.
Dr. Miller is giving me a shout out for what I say.
So this is some tractography data showing us what's happening to the white matter fibers. So for a basal ganglia hemorrhage, you have the singular fasciculus is displaced medially, and that's the fiber that you see in blue. And then you have the superior longitudinal fasciculus, which are these green fibers that are displaced laterally. And the trajectory comes from anterior to posterior, going in between those two fascicles, trying to get to the hematoma. So that's how we plan the approach. Then we make a small craniotomy. We usually pick a forehead crease for the basal ganglia, make a small dural opening, just enough to get the port in. We open the sulcus superficially. We don't dissect to the bottom of the sulcus. Then we picked an appropriately selected length for this port. This has stereotactic guidance. It's connected to our navigation system. We deploy the port, take the obturator out, and then align our optics to that. These are deep holes with very small diameters. So you need to deliver as much light and magnification to the bottom of that as you can. And then once you're there, of course, the hematoma is going to erupt. And you're going to see, once we align our optics to that, we see all of these clots coming to the surface. They can be quite tenacious, so we use that device you see on the right, which is an automated resection tool that suctions and cuts the clot in a more robust way than a traditional suction would. And if we need to, it's a little vessel that I think caused the hemorrhage, we isolate it and cauterize it and get good meticulous hemostasis. So once we're happy with the clot evacuation, then we inspect the banks of our cannulation, make sure that we do good hemostasis, retract that cord, and then at the end of the procedure, we have a pulsatile brain that's decompressed and happy. We've done it in a respectful way to the white matter, and we've done it quickly, trying to get as much clot as we can. So that's what that looks like. We're seeing very good evacuations with that, and patients appear to be doing well. We looked at different studies. This was a multi-center study that we published several years ago in Neurosurgery, where we saw really good evacuation rates, about 90% evacuation rates in about 72% of the patients. Their Glasgow Coma scales were getting better. We saw a series from our friend Mark Bain at the Cleveland Clinic that showed very similar data, even better than us, 96% clot evacuation rates. And then another series from St. Louis University showing similar data. So we took all of that and said, well, there seems to be a signal with this approach. It looks like it makes sense, but we have to put it through the test. And then we decided to put together the ENRICH study, early minimally invasive removal of ICH. We put together a multidisciplinary group with neuroradiologists, neurointensivists, emergency neurosciences folks, and we also brought along some people experts in medical economics to look at the impact of this. This was our data safety monitoring board. The head of it was Mark Hadley from UAB. And we had 37 sites, Mayo included right there, who participated in the study. We started the trial design 7 years ago. Trial started recruiting 6 years ago. Of course, we got COVID, so that stopped us for a while, but we finally completed the study last year. So this was the design of the trial. The purpose was to provide clinical evidence of functional improvement, not just mortality, but actual functional improvement, safety, and an economic benefit when we compare surgical treatment with medical management. It was a multi-center, randomized, adaptive clinical trial. And I'll go into what that means. But it was comparing standard medical management to early surgery defined as within 24 hours of last known normal. And the design did one-to-one block randomization based on two parameters. One was the location of the hemorrhage, and we had two locations, the basal ganglia and the lower location, and based on the GCS at presentation. So greater or equal to 9 versus less than 9. When you design, and I don't know how familiar the audience is with adaptive clinical trials, but adaptive clinical trials are very different from your traditional frequentist clinical trials. In a frequentist clinical trial, you are designing a trial based on your initial impressions and then letting the data fall out. In a Bayesian trial, what you're doing is you take all the available information. So we took all the published trials on ICH and we looked at how the control patients did and what's the natural course of the disease. And then we simulated over 1,000 scenarios. We said, what happens if we start recruiting patients and they go this way or that way? What happens if our loss to follow-up rate is small or large? How do we impute the data when we lose a patient? And after that, then you build certain rules. You build rules for early success. So if you're doing so well, you don't want to expose more patients to the medical management group, and it lets you stop early. On the other hand, if you're doing so poorly, it allows you to stop early futility. So you don't expose patients unnecessarily to harm. It also allows you to do something called enrichment. So you're looking at the data, not the investigators, the statisticians alone are looking at the data. And if one of the two locations is not performing well, you would stop there and enrich in the other location. So if basal ganglia or lobar were not doing well, we would stop one location and then enroll in the rest. These are pre-specified rules. So that's what we did. We did interim analysis once we got to 150 patients and every 25 patients after that. These were our inclusion and exclusion criteria. So 18 to 80 years of age, primary hemorrhages with a GCS of 5 to 14, volumes between 30 and 80, so big hemorrhages. We had to be able to treat within 24 hours of the last known norm. They had to have a good baseline. And then the exclusion criteria was no secondary causes, and no aneurysms, AVMs, dural AV fistulas, etc. And NIH stroke scale had to be greater than 5. So they had to be sick enough for us to detect a difference with the intervention. They couldn't have too much intraventricular hemorrhage, no one with clinical herniation signs, and coagulopathies that had to be reversible to qualify for trial. So the approach we talked about, and that's what we did in the study. And our primary efficacy endpoint was the modified ranking score, but we picked something that is now being promoted and favored and used in trials, and it's a version of the modified ranking score that is called the utility weighted. So instead of going by the ordinal scale of 0 to 6, you actually give more value to what matters to people, right? So if you get to be asymptomatic, that gets the highest points, not just an ordinal scale, but the highest weight. And if you get to be a 1, that's almost as good as being asymptomatic for most patients. So it takes into consideration not only the statistics of about what matters. Traditionally, when you use the modified ranking scale, people dichotomize that. So they say 0 to 3 or 4 to 6 or 0 to 2 and 3 to 6. And that decreases the statistical power of your study. So from a statistical sense and from a patient perspective, the utility weighted modified ranking score is a more powerful tool. And what we did was we took every modified ranking score, that interview was recorded. And then we had somebody that scrubbed the data so that if you listen to the recording, you couldn't tell what group they were assigned to. And then we had a neuropsychologist that was blinded and would grade that. And that was how we blinded the results. So these were the safety objectives. We wanted to look at mortality at 30 days. We wanted to see if there was a change in the volume of the hematoma between the enrollment scan and the 24-hour CT scan. And this was our accruement. So we assessed many patients, 11,600 were in our screening role. The reason for that is many sites, Cleveland Clinic, for example, would put every stroke activation as a patient screen. So many were ischemic strokes. It's not that we had 11,000 ICHs. We excluded a lot of patients that didn't meet criteria, and we randomized 300 patients. 150 were randomized to the surgical intervention and 150 to medical management. After our second interim analysis, when we were at 175 patients, we triggered an enrichment rule. So what that means is that our statisticians looked at the probability of a positive trial. And if we kept enrolling on both, it was very unlikely that we would get to a positive trial. They simulated what would happen if we enriched only a lower versus only an ABG. And if we kept the enrollment only a lower, the probability of a positive trial was real. That's how the rule was triggered. So we reached a statistical futility rule. It doesn't mean that the procedure is futile. That statistically, that made more sense. So then we went to a full enrollment after that. And those were the final numbers of the patients that we enrolled. We had very few patients lost to follow-up, 3 in the surgical group and 11 in the medical group. And we had budgeted for 10%, so 30 patients lost to follow-up. So we were way under that, and these were the observed results at the end. This is our enrollment curve. And when you see that little dip there, it's because of COVID. So COVID really threw a wrench into our enrollment. We were doing really well. And then not only enrollment stopped. We couldn't enroll. Families couldn't come in to consent for the patients. Our research teams got decimated. So our research coordinators could not come to the hospital. They were banned. And many people that were in nursing, that were doing research, went back into clinical nursing because they were getting paid better. So that threw a wrench, but we got back on track and we got the study complete. So these were our demographics. So our mean age was 62 years, 50% of the patients were female, 70% were white, 25% were Black, 6% were Hispanic or Latino. Comorbidities were fairly well balanced with diabetes, hypertension, previous stroke, tobacco use. And that one here. And these are our baseline presentation characteristics. So the overall GCS was 11. The NIH stroke scale was 17. The average volume was 50.5 cc's. We had 69% of the patients with a lobar hemorrhage and 31% with a basal ganglia. That's because of enrichment. And these were our time metrics. So from last known normal to arrival in the ER was about 3.7 hours. From randomization, from last known normal to randomization was about 13 hours. And from last known normal to surgery was about 16 hours. This is a metric that I'm very, very proud of. From randomization to surgery was 1 hour and 27 minutes. So once the team identified a patient, the hardest part was getting consent. We were looking for families, trying to get consent of these patients that come in. They cannot consent themselves. And once we got them in, the time to surgery was pretty quick. So how did we do? So here's our mortality data. Our overall mortality was 21.7%. It was 20% in the surgical group and 23.3% in the medical management. That's great. Other studies had shown a benefit in mortality, but we wanted to go further than that. So this is our 30-day mortality. So in the early populations, we had 27 mortalities in the medical group and 14 in the surgical group. So that was statistically significant. We like that a lot. Early mortality is great. This is how the data looks going up to the 6 months. So in the beginning, there's a lot of separation, but as things go farther along, the gap narrows substantially. These are sick patients, obviously. They are vasculopathies. They have a lot of other comorbidities. So they tend to get sick over time. But that's how we did. These are the modified Rankin scores at 3 to 6 months, which is what people will typically do. And this is in a dichotomized fashion. When you look at 0 to 3 versus 4 to 6, at 3 months, 41% of the surgical patients had an MRS of 0 to 3 versus 32% in the medical management group. And at 6 months, there was still a substantial difference, 50% in the surgical group versus 41% in the medical. But we designed a Bayesian trial. And when you look at Bayesian trials, what you get is something called a posterior probability of success. So this is what we saw in terms of the mean utility weighted MRS. Okay? So there was a difference in the lobar group between surgery and medical management that was very substantial, very robust. In the basal ganglia, there was essentially no difference. When we combined the two, there was still a very substantial difference in the efficacy of the study. And this is how we look at it in terms of the posterior probability of superiority. So for the basal ganglia, not a very robust effect. For the lobar location, incredibly robust. And the overall was a 0.98. So what does that mean? This is what it means. This is the probability that the intervention was possible. Everything to the right of that line was positive probability. So very, very strong. And this is what it was for the two locations. So you see that the basal ganglia comes down to the middle. So what does that mean? It means we don't know, because we stopped accruing patients for that. and it fell right in the middle. So that's still an unanswered question. But for lower is the red curve, and that was extremely positive. These are the modified ranking scores at different time points. This is at discharge, and what I want you to see is how the numbers are going to shift. You look at the surgical group versus the medical group at the top. And again, we knew that mortality was better at discharge in 30 days. So there is that. Here's at 30 days, and we saw that already. The numbers start to shift. And here is at 90 days. And then the money shot is going to be 6 months. I'm going to show you that in a minute. When we look at the modified ranking scores in an ordinal way, so in a traditional frequencies approach, these are the MRS at discharge. It was statistically significant for surgery at 30 days, at 90 days, and at 180 days. So doing traditional non-Bayesian statistics, the trial was positive for the MRS at each one of those time points, which was great. We love that, see that. And this is the most important part. So this is the 6-month data. You look at the surgical group at the top versus the medical group at the bottom. And you can see the patients between a 0 and a 3. So from your gray to your yellow, you can see how that shifted substantially to the left. And that's the mean utility weighted MRS for this group versus that group, and the difference of 0.08 with a 90%, 98% posterior probability of success. This is how that happened over time. You can see MRSs between discharge to 180 days for the medical group on the left, surgical group on the right. You can see how these patients go from the acute stage to the 6-month follow-up, and they start to get better and stabilize. So this was the first surgical study to ever show a benefit of surgery for ICH. And we could not be more thrilled. So why did that happen? We think the meat of that is here. So what was our end of treatment volume? 14.9 cc's. The change in volume was we decreased the volume by about 44 cc's, which was an 87.7 median percent reduction in hematoma. So we got the job done, and we think that mattered. 71% of the patients got to a greater than 70% ICH reduction. And that's what we think made a big difference. So this is, of course, a reduction of the hemorrhage volume. That was significant. We knew that. We looked at whether reducing the ICH volume or getting to an end of treatment volume made a difference, and it turned out that it did. So it tells me that our results are based on the fact that we were able to substantially reduce the hematoma and to get to a very small end of treatment volume. We're starting our subgroup exploratory analysis right now, and one of the key questions we had was about timing. So did intervening earlier make a difference? So we have 8 hours and 12 hours are metrics. And we saw a signal. It didn't reach significant, but the less than 8 hours, we're looking at the utility weighted MRS here. The higher the number, the better. So 0.105 versus a 0.08. So less than 8 hours seemed to do better. And the posterior probability of success was not reached for that, but it was showing a signal. Same thing for the 12 hours. So less than 12 hours versus greater than 12 hours also showed a signal. So it didn't reach that statistical significance, but here it is with the MRS of 0 to 3 at 180 days. So it was 0.415 versus 0.622 for the surgical group. And the p-value for that was getting towards significant in the 8 hours, even more so for the 12 hours. So didn't hit those marks. We don't know about time, but we think earlier is better. Here's our location data. We know that lobar hemorrhages did better. That's why we enriched in them. We saw a signal in older patients. That may be because lobar hemorrhages happen more in older people, but over 65 tend to do better, and females did better overall in the trial. There are many hypothesis about that, the protective role of hormones in stroke patients is something that is well known. NIH stroke scales were not predictive. We break it down into 17, 10 to 17, or greater than 17. It didn't matter, but GCS did matter. So patients that come in with a GCS of 9 or greater have a greater likelihood to do well. And then volume, we explored just initially 40 as a cutoff, and we didn't see a difference between over or under 40. Length of stay, we hit the mark. So we were able to reduce the length of stay substantially. So the mean was 9.6 days in the medical group versus 7 days in the surgical group. And that was statistically significant. And the overall, that was for the ICU. For the overall length of stay was 17 days for the medical group and 14.7 in the surgical group. And that was significant as well. So what are the conclusions of the study? This is the first study to ever show a functional benefit in addition to mortality for patients with ICH. The procedure was safe. We substantially reduced the amount of clot. We improved and modified ranking scores to 6 months, and we decreased the length of stay and the ICU length of stay. We also looked at the number of complications, significant adverse events, and they were substantially lower in the patients treated surgery. And the overall benefit of the approach appears to be from the strong positive effect on the lower hemorrhages. So you don't get to do a study like this without patients and families that trust you. I don't know how many of you were part of the study here, but coming and consenting a family and tell them you're going to surgery versus no surgery, it's a tremendously heavy question to ask a family, especially in the heat of the moment. That's the tough part about doing stroke trials, that you have to make a decision immediately. And they trusted us with that decision. And then we had 37 sites like yours that worked incredibly hard through the pandemic to get this data, to follow these patients up, to bring them back. And a huge group of research folks that put this data and analyze it together. So I think it's a tremendous accomplishment for our group, for our specialty. We opened the door to treat a disease that had no surgical answer before. We have a lot of work to do, but this is, I think, very, very good news for 100,000 patients a year that show up in the United States. So thank you so much for the invitation. Happy to take any questions.
Thank you, Bruce. Beautiful presentation. Maybe I can kick it off with a couple of questions. Then I see already Robbie talked at the hand. So I'm going to kick it off with a couple of very quick rapid fire questions. Number one, cost, medical versus surgical. I imagine is cost effective for our world, but that's one. Number two, seizures, control for the lower. And number three, what happens to the laboratory of these patients if you look at Epic, whatever electronic medical record? Is there any evidence that they are actually fighting this inflammatory response, which you alluded to at the beginning, which I know if you can see it on the scans, I mean, the amount of edema and things like that. So those are three things.
Yeah. So the first question about costs, we are looking at that. There was our group from University of Pittsburgh. They're doing the economic analysis. We got a first look at the data, and I can tell you that the business case is being made, meaning when you look at average cost versus average reimbursement, there's a significant impact, positive impact to the institution, and we're looking at the long-term analysis of that in terms of benefits to healthcare as a whole. Mm-hmm. But with the length of stay reduction, I think we're going to see a lot of positive data, right? Because the average cost of a day in the ICU is about $5,000. So if you're getting 2 days earlier out of the ICU, that's substantial. Now, when we look at discharge destination, that's what we're doing right now. That really moves the needle. Are you going home? Are you going to LTAC? Are you going to skilled nursing? And what is the cost per day of your subject care? So we're exploring that right now. Got more data. The second question was seizures. So we looked at the overall serious adverse events, and that included patients that went into status epilepticus, for example. I don't have the data specifically on seizures right now. We are looking at that. And I'll have to get back to you on that. And what was the third
The
question?
last one was, what happens to the, if you, because I'm sure
Oh,
you're
yeah.
tracking their laboratory values, blood inflammatory responses, ESR, CRP. I would imagine that your body is mounting a response to this as well, but I don't know if that's been looked at. But this is the
Not yet
perfect
in
population.
detail. So what we did in the design was we only collected transgressions.
Gotcha.
So not every data point, every white blood cell count, but only when they were truly abnormal. So we do have the ones that had a higher inflammatory response. And we're going to dissect that data down. By looking at the adverse events, that tells us that we did move the needle there, because a lot of these adverse events in the ICU are driven by this increased pro-inflammatory state, right? Patients that have systemic hypercoagulability and they have higher risk of infection and so on and so forth. So we are going to dig into that data. This is very hot off the press. This is going to New England Journal in a week or two at the latest, and hopefully it will be out very soon with the primary outcome measure. We have a lot of follow-up data. We have a data dictionary that has more than 2,000 data points that were collected. So this is a treasure trove of information that we are going to very happily share with all of our collaborators across science to mine it together, to understand more about this. We're really looking into the basal ganglia and see if we saw a signal. What was positive about it? What's the next direction there? Should we limit volume? Should we limit age? Should we do it sooner to see where the signal lies? Because anecdotally, just like we felt that doing surgery overall made sense, those of us who treated these patients in this manner for the basal ganglia saw a lot of anecdotal positive data. So we need to look back and see, where is the signal? What are the subset of patients that we think can do well, and dig into those.
Beautiful. I see Robbie. Robbie, you want to unmute yourself?
Sure. So, Gustavo, kudos, basically hats down. This is the biggest, latest splash in neurosurgery. A disease that's horrible, high mortality, high morbidity, so many trials in the past that were designed, I think, suboptimally in the past. And this is the first one that we see ourselves turning the corner. Just like stroke care, I mean, we saw initially Mr. Clean, and then after this triggered the cascade of trials that were all positive. And what you're saying in this trial now is nothing new to people who really care for patients, but you're the first to show it in data. So we know there is more, and this is probably just the tip of the iceberg. My question to you is, how do you see the subsequent steps, and how you see, like Dr. Quinones' question is inflammatory markers? I mean, looking at the right thing is the most important thing for trials. At the Aruba and all those things, we designed trials in a way that we looked at something that is not different. And then we concluded that doing something is not, when we're not looking at the right thing. So how do you see the sequence and this chain cascade happening from your level, looking at all this data? And what's your advice, for the youngsters, if they want to look at a trial, how to design it in 2 years or in 1 year from now?
Robbie, thank you for that question. So where we go from here, I think the first part is going to be to get to the guidelines for the next version. So they're going to be updated, and our expectation is that with this level of evidence, surgery for lobar hemorrhages is going to be a class 1 recommendation. We're going to be pushing hard for that, and I think that's going to change care. We have the safety data and we have the efficacy to do this within 24 hours. We're going to explore time a little bit more, but biologically, it still makes sense to do it sooner. It's a little bit of a more difficult question than ischemic stroke to break it down as well as ischemic stroke is done where you have data by the hour and sometimes by the minute of revascularization and what that looks like. But I think as the procedure gets wider adoption, we'll have enough collective data, maybe in a registry format, to dig into the time a little bit more. But the biggest homework that we have after this trial is the basal ganglia. What are we going to do with those? We purposefully excluded thalamic hemorrhages because they frequently dissect into the midbrain, and those patients are obtunded for longer. So even if you remove the ICP problem out of the equation, your intensivists cannot extubate the patient because they're too obtunded. So they end up getting longer ventilation days, they get tracheostomies more frequently, and they eventually make it to similar MRS numbers in our pilot data, but it took way longer. That's a year follow-up, not a 6-month follow-up. So looking at what we do next, anterior basic ganglia will be next, and then thalamics will follow. And I think keeping those things separated has finally allowed us to see through the clouds and understand what's happening. And then in your second question about designing trials, I think the stroke world really told us what the lesson was. There were a lot of positive data with thrombectomy that was put to the test using frequentist trials, and the trials were negative. And the intervention almost died. People took a step back and said, wait a minute, let's look at the right trial design for this. And when the right trial design was selected, the studies were positive. So you have to be very, very careful about understanding what is the best design for the question you want to answer. More and more FDA and the regulatory agencies are pushing for these Bayesian trial designs, because as the trial goes along, you learn and you adapt. And that is a more efficient way, it's a safer way for patients, and it costs less money. Because if a trial is not working, you stop, and you stop early. And you need sample sizes that are more data-driven, more specific, so you can shrink that down too. So I think we'll see more of these Bayesian adaptive trials become the standard, especially for interventions like this that are multi-location, that have multiple data points. You can really use the power of these designs to answer these very difficult questions that in a traditional model, when you start to put multiple locations or multiple data points, the statistical power goes down and you may miss just because the sample size wasn't good.
Well, thinking about the thalamic ones, you have already some preliminary data, right? So you could potentially, and I'm sure with your team, you're doing this, which is becoming more popular through mathematical modeling, which is called virtual models. We actually implemented some of that in the trial of the grant that I was telling you with Christine Swanson, because you alluded to that already. You can actually create these simulations in which you already have. I wouldn't be surprised if that's going to show positive, because of everything else, it's mass effect, swelling, all this stuff. We know that when blood clots, swells a little bit more and also attracts fluids. I mean, there's a pathophysiology that you're dealing with, but as you said, it's going to be only a matter of time, but you can potentially already begin to get a sense of that.
Absolutely. I think one of the things about thalamic hemorrhages is that they often will cause obstructive hydrocephalus. They very frequently rupture into the ventricle and cause IVH. A lot of the morbidity happens from acute hydrocephalus. So patients come in with a herniation syndrome because of acute hydrocephalus. That's why we purposely also excluded big IVH from there. But there are a lot of opportunities to go into that. I think thalamic hemorrhages are challenging because the axis is challenging. When we did our DTI analysis, we did an exercise. We tried to predict what was the safest path without tractography. And the location of the ascending fibers of the superior longitudinal fasciculus, the location of the ventral fibers of the arcuate fasciculus, and the displacement of the optic radiations was oftentimes unpredictable. You could not guess it, and then you need tractography to be respectful of that. So what does that mean? And the example I always use is a visual apraxia. Let's say that your patient is an architect they design on AutoCAD 3D buildings all day. If you damage the ascending fibers of the SLF, their three-dimensionality is gone. That patient is functionally disabled. So if we do our 6 a.m. morning round exam, yeah, that patient is going to be oriented. They have no motor deficits. They have a fluent speech. But if we test them a little bit longer, we've damaged their livelihood. So understanding those patients is going to take a little bit longer, but it's a fascinating group because of that, because the power of imaging, and with image analysis, maybe we can start using AI to predict better where these fibers are going to be displaced based on the image.
Beautiful. I don't know if Kai or David, are you guys still on the line?
Yes.
Kai.
Yeah,
Oh, yeah. Go ahead, David, and then I'll have Kai. Go ahead, David, please.
Yeah, no, Dr. Pradilla, this, I mean, this is, I mean, for those of us who remember those pivotal trials in 2015 were thrombectomy, it just felt like, and I don't have enough congrats to, this is just hugely important work. And yeah, for taking care of patients in the ICU, I think we saw in the first few cases that, were randomized to intervention. I mean, we were extubating one guy like the very, pretty much within 24 hours got extubated. I still remember one of our coordinators, I mean, he gave permission. We took a photo with him and he returned fully functional and back to work. I mean, it was definitely not what we're used to seeing with this disease. So huge congrats.
Beautiful. Thank you, David, for your leadership. And Kai also, go ahead, Kai, please.
One of the questions I had was versus the Stitch 2 trial where they just did lobar hemorrhages. Where do you see the difference between
We lost you there for a little bit, Kai, but can you repeat that? You're probably moving or something. Traveling.
kids? The Stitch 2 trial basically didn't show any significant difference between the lobar hemorrhages. Where do you think the biggest difference between this trial and the Stitch 2 trial?
Yeah, I think this is hypothesizing this, but Stitch had a very broad surgical protocol, correct? So when you looked at the surgical manual, all it said is treatment at the discretion of the treating surgeon. When you looked at what was actually done, remember, these are 87 centers that were participating across the world. 78 countries participated in this. How do you standardize that? It's tough. So some centers did a hemicraniectomy, a partial frontal or temporal lobectomy, and they obviously left the bone off, left the dura open, and that was the intervention they did. Other centers did a small incision, small craniotomy, microsurgical corticectomy, and a very conservative clot evacuation. Massively different operation. So that's one part. Of the patients that had very aggressive treatment, a lot of them probably got a lot of white matter injury because you didn't need to take out a third of the temporal lobe to get to the hematoma, but you functionally caused a disconnection syndrome. And if you look at outcomes of those patients in the long term, they're going to have deficits. We see it in trauma. Yes, we come in and you have to do a temporal lobectomy because the brain is herniated. They're going to occlude their posterior cerebral artery and have a stroke and die. So you have to take it out. But they have disconnection syndrome. We're taking out their uncinate fasciculus. That connects the frontal and the temporal lobes at the basal level. And they have a lot of affective emotional issues. They have a lot of memory processing problems. So we hurt these patients when we do these. We used to not evaluate them enough, but with the power of the Human Connectome Project, now we have DTI data that shows us these connections. And with neuropsychological testing, we see the deficits very clearly. So I think that was part of that, of the reason why the protocol was too broad. A lot of them were way too aggressive in doing the operation. The other thing that we don't know in the Stitch, they never reported how they did. There was no requirement of sending their postoperative scan. So they never measured how much clot was removed. So we really have no idea how the surgical performance was on the Stitch 2 trial.
Major differences. One question. Thank you, Kai. Anything else, Kai, to follow up? I think that you're, I see you're muting, Kai, but maybe you're moving or something. We cannot hear you. I'm gonna pivot right here to Paola, Dr. Mead, Kai. I'm sorry, we cannot hear you.
I think Olu wants to.
Olu, yes.
I was gonna make a quick comment. I got rid of the calling me in the OR, but first of all, the whole thing was excellent. I really enjoyed what the data you showed about the volume. We've kind of shown, in terms of, the amount of volume remaining and how important that is, because, I mean, I personally wasn't aware of that for, ICH in particular. We have some of that data coming out for Domo with Carlos and AK. I had some questions about the trial, but we don't have much time, but I have interest in designing some of those. So it's beautiful to see how, with the enrichment versus futility. So I definitely have to connect with you in the future and just, pick your brain more on that. But thank you so much.
Thank you.
I told Olu that we're primed for spine trials like this, especially for spine. They're not in neurosurgery in general, obviously, but it's amazing. So thank you, Olu.
Thank you so much.
One more question. I'm sorry that we're keeping you longer, Gustavo, but it's perfect, actually. Well, you can see a lot of people are still online listening. Paola.
Thank you very much for your talk. When talking about other countries, for example, I'm from Mexico, there's like, do you really need the brain pad for this, for your trial to be successful? Because DTI is easier to get, but not all of the centers have access to brain pad, much
Yeah.
less neuronavigation.
Yeah, that's a very good question. So my simple answer is the protocol that we used was very specific. You had to use the technology that we put together, and you had to use it the right way. That's a lesson we learned from our endovascular and spine colleagues. So let's say you want to use the newest flow diverting stent. What do you have to do? You have to go to course. You have to be proctored, and then you can do it. Same with spine. You want to use the newest artificial disc. You have to go to course. You have to get proctored. You have to use the technology as it was meant to be done. So I can only translate the results of the study to when you use this technology. So I can't answer your question. Can you get the same data without it? I can tell you that when we did traditional surgery as done in the stitch trial, it didn't work. So there are other systems that are being designed across. They will have to be tested in the same way. I think as long as you maintain the same principles of using a trajectory that is respectful to the white matter and using an approach where you can do good microsurgical technique, you can see what you're doing, you can do good hemostasis, and you're not injuring the brain around you, you can intuitively say that the benefit will be there. But there are many efficiencies that were built into this so that the procedure was short. It was repetitive, it was easy to do, it was easy to learn. Your staff could pick it up easily. So what we try is to leverage technology and take the surgical virtuosity out of the question. What we wanted is, do you have to be Mike Lawton to do this procedure? The short answer is no. And then we show it. We have in our trial 37 centers that are very different. We have private practice hospitals entirely run by private practice neurosurgeons with PAs and NPs. We had surgeons that were a few cases into the procedure. They had built-in experience that they had not done 100, they done maybe 15 or 20. And we had surgeons that had many years of experience. So we took all of that in the mix. And I think with leveraging the technology, the experience level and the expertise and the surgical ability decreases, and you can still get a good outcome. And that was the point, because these patients sometimes cannot wait to be transferred. Some of them will definitely benefit from coming here. But if they're in a rural hospital that is 4 hours away and the weather is bad and they can't be flown in and it's going to be 4 hours in an ambulance, you have a neurosurgeon that has the equipment, they can do the procedure Then they can transfer the patient for subsequent care, but at least they address the early mortality. The positive spot sign patient that is bleeding actively, they can stop that and and get the patient to the next level of care.
My argument, and I do believe that the study is designed to use this technology. Having seen, Gustavo went through the video very rapidly that he showed the evacuation, and there were several surgical pearls right there. Number one, he opened the sulci, preserved the veins in the cortex, and you can see it when he takes a tube out, all the veins are preserved. That's not to be trivialized, number one. Number two, he uses the navigation system. You can no matter how of an expert in knowledge of anatomy you have, you can get so easily lost going into the brain, especially if the bleeding is a little bit deeper, and ended up on the corner of the clot and ended up taking some white matter tract that you didn't intend, and the clot is more medially, more superiorly, more posteriorly, whatever. With this navigation system, you really get into the center, the core, whatever you want to do, and potentially preserve those white matter tracts, which I think Gustavo emphasized that is important. So there were some surgical pearls right there that he showed that are beautiful, and they're beautifully illustrated in that video. There's a lot of surgery right there, number one. Number two, I was talking, Gustavo was also, but if you look at some of the original papers that we did with Vicar, also with Chan Rasa, we were using Vicar way before we using the brain path. Vicar was introduced by George Jallo. We were, doing a lot of these tumors. But even last night with Dr. Hakim, he was asking me about Vicar. I said, I like this system. The problem is that you don't have the ability to put the navigation system probe and then go into exactly where you want to go. And that is, to me, if you are deviated 1 centimeter in the surface, and then you're going down in a trajectory, you're 1 centimeter away, you can easily end up in corticospinal tracts, into some tracts that you didn't mean to, and you ended up creating more morbidity than you helped. So that's why I do agree with Gustavo. I think the study is designed for this. I think I wouldn't be extrapolating yet this data. So I think you use the technology and navigation, use the path. The other thing is that he's going in and out with the instruments, and the brain around the path is preserved. Once you take that out and you use just the bipolar, and I was showing the students the other day, once you start doing this, you start banging on the veins on the surface. So those are the little pearls that are very valuable.
I'm so glad you mentioned that, because one of the things, 40 years ago, there were two people, Gassi Yastergill and Lenny Malice, who said, if you can access the subcortical space through a sulcus, that is better than transecting the cortex. And they developed a transsulcal axis for everything. If you go to Yastergill's microneurosurgery, I think it's volume 2, he has all the transsulcal axis points there. And Lenny Malice used to cut a piece of a glove to cover the sulcus, put it on both sides, and avoid banging on the banks tissue. But accessing this transsulcally is protecting real estate that is valuable. Even when you're very gentle and you make a small corticectomy and you say, I'm only going to make a centimeter opening to get to, let's say, an interventricular lesion. At the end of the procedure, you're going to have 3 times the size of a hole.
Yeah.
Because of Alfredo's saying, you just constantly banging against that, and the defect is bigger. So maintaining those banks of the cannulation protected makes a lot of sense.
Yes. So beautiful, beautiful. David, thank you for your leadership, and Kai for working with Gustavo in this very, very important study. And we're looking forward to more data, Gustavo, more present, a lot of sub-analysis, cost, everything that you mentioned is going to be absolutely beautiful. So thanks, everybody. Thank you for staying. We're staying longer. This is, you can see a lot of people stay online. Rooms will fill with people as well. So thank you for showing. And we're going to have a couple of days with Gustavo. I think the fellows, we're going to take them to places, more meetings. We meet later, and we have some work. All right? Great. Thank you, Gustavo.